Hi, I'm Dr. Adrian Holm, Assistant Professor in the Division of Gastroenterology at the University of Iowa Hospitals and Clinics. I'm here to introduce Dr. Henning Gerke, who is the Director of Endoscopy at the University of Iowa Hospitals and Clinics, and we're here to present his paper, in which he's the lead author, on the efficacy and safety of endoscopic mucosal resection to completely remove Barrett's esophagus, an experience in 41 patients. So let me start with our first question. Why did you do the study?
Thank you, first of all, for your introduction, and thanks also to the editors of Gastrointestinal Endoscopy to allow us to present our study here. So the objective of our study was to better understand the role of endoscopic mucosal resection for the treatment of Barrett's esophagus. And before we started to perform endoscopic mucosal resection to completely remove Barrett's esophagus, the main endoscopic modality to treat dysplastic Barrett's esophagus was photodynamic therapy. But there were a lot of problems with that method, including adverse events such as phototoxicity and a high rate of stricture formation. The advantages of mucosal resection, in contrast to ablation, is that not only do we treat the abnormal Barrett's epithelium, we also harvest tissue for very accurate histopathologic staging, and we can treat not only flat mucosa but also elevated lesion. And then the concept of completely removing Barrett's esophagus rather than just treating focal abnormalities was very appealing to us, and we were encouraged to do this by an abstract that at that time was just presented by a Dutch group reporting fairly favorable outcomes.
Very good. So what technique of endoscopic mucosal resection did you use?
Initially, in a few patients, we used cap-assisted mucosal resection, but then we soon switched to a bent ligator-assisted mucosal resection when a bent ligation device for this purpose became commercially available. And the reason was that we felt that it was very easy with that device to achieve removal of large areas of Barrett's mucosa through side-by-side resections.
Can you describe the design of the study?
Our study was a retrospective study that included 41 patients in whom complete removal of Barrett's esophagus was attempted with endoscopic mucosal resection. And most of these patients had high-grade dysplasia. Some of these patients had superficial adenocarcinoma. 27 of these 41 patients had circumferential involvement of the Barrett's esophagus, and the median length of the Barrett's esophagus was 3 centimeters, ranging from 1 to 10 centimeters.
And what were the results of the study?
We found that endoscopic mucosal resection was fairly effective in eradicating Barrett's esophagus. We achieved a complete remission of all Barrett's metaplasia in 78% of patients, complete remission of all dysplastic Barrett's epithelium in 85% of patients, and complete remission of all high-grade dysplasia and or adenocarcinoma in 95% of patients.
So there were some patients in which Barrett's esophagus could not be completely eradicated. Do you have any thoughts on why that might have been the case?
Yeah, you're correct. We had some patients that only had microscopic, non-dysplastic Barrett's esophagus or very small areas of Barrett's esophagus at the gastroesophageal junction, while there were others that had still very large areas of Barrett's esophagus that we could not eradicate. Part of the problem may be either incomplete resection, although there are some patients where we were confident that we resected all visible Barrett's epithelium and they still had Barrett's esophagus on surveillance. So we wonder whether it could be related due to less than optimal acid suppression leading to immediate recurrence of Barrett's epithelium, or from induction of recurrence through neighboring Barrett's epithelium.
So what are some of the disadvantages of endoscopic mucosal resection?
The main disadvantage we found is a high rate of stricture formation, especially after circumferential resection. And we saw that both in patients in whom we stepwise performed circumferential resection, which we preferentially did, as well as in patients in whom circumferential resection or near circumferential resection was performed in a single session. The rate of stricture formation was 44% in all patients and 60% in patients with circumferential Barrett's esophagus. There were other complications such as minor bleeding, but that was easily handled. and we had perforations in 2 patients, one directly related to mucosal resection at the resection site and the other perforation due to traumatic endoscope insertion, and both were fortunately successfully managed conservatively.
What are some of the limitations of the study?
The main limitation is the retrospective design, which also harbors a problem with selection bias. Initially during the study period, we offered endoscopic mucosal resection fairly unselectively to all patients with high-grade dysplasia. But later during the study period, we had radiofrequency ablation available at our institution as an alternative and safe method, and EMR was then only very selectively used based on the endoscopist's judgment. So if using EMR more unselectively in a prospective study, we expect to probably find an even higher rate of complications.
And perhaps an even lower rate of eradication of Barrett's.
That is correct. Yeah.
So what are the conclusions of the study?
The conclusions are that EMR, although very effective for eradication of Barrett's esophagus, has a high rate of stricture formation, especially with circumferential resection. And therefore, at our institution, we switched our strategy, and we now preferentially perform EMR focally for visible lesions, and then treat the remainder of the Barrett's esophagus with radiofrequency ablation. There are still some exceptions where we perform circumferential EMR, especially in patients with short segment Barrett's esophagus, and those are, for example, patients with circumferential nodularity and with concern for adenocarcinoma that cannot be clearly delineated endoscopically.
Very good. That was a very nice study. Thank you for taking the time to share that data with us.
Thank you, and thanks to the editors of GI Endoscopy again to allow us to present our data.